Good afternoon, everyone. Welcome back from the break. I'm Nikki Burney, a nurse practitioner in the division and one of the assistant course directors. So far, we've had a fantastic day two, but there's actually more. We have another four excellent talks coming your way this afternoon. To kick us off and keep the momentum going, I'm thrilled to welcome back Dr. Lisa Vercollone for her second talk entitled Inpatient Management of Opiate Use Disorder. Please welcome back Dr. Vercollone.
Thank you, Nikki. So we're going to spend the next hour now talking about opioid use disorder, and this is specifically in the inpatient population. I have no disclosures. So we're going to spend some time talking about the FDA-approved medications for opioid use disorder. We'll talk about starting methadone in the inpatient setting, how to treat acute pain in the patient who's on methadone and the patient who's on buprenorphine. We're going to talk about buprenorphine precipitated opioid withdrawal, which is an increasing problem. And then we're going to talk about how this heavy chronic fentanyl use has actually altered the pharmacokinetics of the drugs, of the drug. And we're going to then go through various strategies to initiate buprenorphine in the era of fentanyl. Okay, so when we're talking about starting medication for opioid use disorder, what are our goals? Our goals are not quote unquote detoxification. Our goal is really to prevent euphoria, prevent withdrawal, prevent cravings, and prevent death. We know that if we take a patient and taper them off of opioids, and they're completely off any opioids, that the chances that they're going to remain abstinent are very, very little. And so we want to put patients on medication for opioid use disorder. These medications, these medications are designed to prevent the euphoria and to prevent patients from going into withdrawal or even treat the present withdrawal, to prevent cravings and prevent death. And in doing so, we take somebody from having an addiction to having a physiologic dependence when we're talking about initiating methadone or buprenorphine. Because this is a common misconception. Patients think that they're trading one addiction for another if you put them on methadone or buprenorphine. But we're taking all those addictive behaviors, those negative consequences to seeking out the drug away, and the patient is therefore left with the physiologic dependence. And that is our goal. And so there are three medications that are FDA approved for opioid use disorder. There's methadone, which is the full agonist to the mu receptor. There's naltrexone, which is a blocker of the mu receptor. And then there's buprenorphine, which is a partial agonist and antagonist. So we're going to go through each one of these. All right, so there's naltrexone. Naltrexone is a full mu antagonist. So it blocks the mu receptor fully. It does not stimulate the mu receptor. It comes in various formulations, but really when we're talking about opioid use disorder, the formulation that we would most commonly use would be the IM injection, otherwise known as Vivitrol, 380 milligrams once monthly. The problem with naltrexone is because it's not stimulating that receptor, it eliminates tolerance. And so if patients are on this medication and then they become non-adherent, they've lost their tolerance. And therefore, if they relapse, they're at higher risk for overdose. It's also an incredibly difficult drug to get somebody on if they have been using full mu agonists such as fentanyl. Patients need to be opioid free for 7 to 12 days, which is a very hard thing to accomplish because the patient would have to go through withdrawal for that period of time. And there's no mortality benefit. So when we're looking at medication for alcohol use disorder, or opioid use disorder, we are really focusing on methadone and buprenorphine. There have been a couple studies that have kind of compared these three options. There was a study that was published in JAMA looking at almost 41,000 adults with opioid use disorder, and they found that only treatment with buprenorphine or methadone was associated with reduced risk of overdose. Shortly after, there was another article that was published in the Annals of Internal Medicine, and this was looking at about almost 18,000 patients. And what they found was only methadone and buprenorphine were associated with decreased all-cause mortality and opioid-related mortality. So in looking at naltrexone will prevent euphoria because it's blocking the mu receptor, but it doesn't prevent withdrawal. and it's not preventing cravings because it's not stimulating that receptor, and it doesn't have mortality benefit. So let's move on to methadone. So methadone is a synthetic full mu agonist. It is metabolized by cytochrome P450-3A4. Therefore, many drug interactions we need to be mindful of when we're starting the medication. In addition, there's a lot of variation in dosing from person to person. There's a high interpatient pharmacokinetic and pharmacodynamic variability with this medication. With this medication, it is also used to treat pain, as we know. The analgesic effects of methadone, though, really only last for about 6 to 8 hours. And traditionally, in patients who are being treated for opioid use disorder, we're giving this medication once a day. It still remains highly federally regulated. It has a daily commitment. For the most part, patients do need to go to the clinic, go to a methadone clinic to be dosed. And these clinics have very strict protocols that have to be followed. And these protocols were created back in the 1970s and really haven't changed. So the federal government actually regulates how quickly methadone clinics can titrate a patient on methadone. The nice thing about methadone is there's no risk for precipitated withdrawal if a patient is requesting to transition to methadone. There has been a lot of talk in the recent years about really overhauling how the federal government treats methadone and looking at better ways than having patients go to methadone clinics. There is the Modernizing Opioid Treatment Access Act that was introduced in the Senate in 2023. And really what this is about is really arguing that those physicians who are boarded in addiction medicine or addiction psychiatry should be able to start these medications in the outpatient setting. Patients should be able to go to the pharmacy, to retail pharmacies to pick up their medication. This would also allow methadone to be included in the physician drug monitoring program. So fingers crossed, we do start to see some improvement in how the federal government oversees methadone. Next, we're going to talk about buprenorphine. So buprenorphine is our partial mu agonist. It's both a mixed agonist and antagonist to the mu receptor. So it sits on the mu receptor, it stimulates it partially, but it blocks it from anything else wanting to bind. It has a very high affinity, meaning that it will rush in and attach and bump off anything else that's on the mu receptor, essentially. And it has a low dissociation. So once it's attached, it does not want to come off. It is hepatically eliminated, and the dosing is anywhere between 8 to 32 milligrams a day. It too has a short analgesic period of 4 to 6 hours. It's available in both a monoproduct and in combination with naltrexone. The good things about buprenorphine is that it does reduce the risk of overdose. Patients on buprenorphine that relapse to fentanyl or any other full mu agonist are less likely to overdose. It is protective. And it also has a ceiling effect on respiratory depression. The concerns, the big concern in the past was that prescribers had to have an X waiver. Fortunately, we no longer need the X waiver as of 2022. And so now you do not need this special license in order to prescribe it. The problem that remains with buprenorphine is precipitated withdrawal. And so we're going to talk quite a bit about this throughout this presentation. And so just briefly, what is precipitated withdrawal? So you have a patient who comes in, let's say they're using fentanyl. So they have this full agonist on board. This full agonist is stimulating that mu receptor fully. Now, buprenorphine, it will stimulate the receptor partially. So if somebody has fentanyl on board, and you give them buprenorphine, buprenorphine will rush in, and because of that high affinity and low dissociation, it will bump off fentanyl or any other full mu agonist. It will bind to that receptor, and within seconds, that receptor goes from being fully stimulated to partially stimulated. That dramatic change in stimulation causes a very abrupt and violent withdrawal syndrome that's far worse than a natural opioid withdrawal. And patients become incredibly sick, and it's difficult to manage, and it really causes patients to suffer PTSD from having this situation and are often reluctant to ever try buprenorphine again when it happens. So in looking at methadone and buprenorphine, so in looking at like what are we trying to achieve, both of these medications will prevent euphoria, they'll prevent withdrawal, they'll prevent craving, and they both have mortality benefit. So let's go on to a case. We have a 23-year-old man with a past medical history of opioid use disorder who's injecting fentanyl daily. He's admitted for fever and bacteremia and diagnosed with endocarditis. And now he's requiring IV antibiotics. He is motivated to be in recovery, but he quickly shuts down any discussion about starting buprenorphine after experiencing precipitated withdrawal a couple months ago. This is not an uncommon story any longer. It is really important that we ask our patients if they've experienced precipitated withdrawal, because most patients at this point have experienced it. And once they do, as I mentioned before, it's sometimes difficult to convince them to try it again. And so in this situation, this patient is requesting to start methadone. So what is the best approach for starting methadone while this patient is hospitalized? A, federal regulations prohibit the prescribing of methadone in the inpatient setting for the treatment of opioid use disorder. B, start methadone 10 milligrams every 4 hours as needed for cows greater than 8. C, start methadone 30 milligrams daily. Or D, B or C. So the answer is B or C. You can absolutely start methadone in the inpatient setting for a patient who has opioid use disorder. It is a common misconception that in the inpatient setting, we are unable to do this. The only time that we are unable to start methadone is if our primary admitting diagnosis is opioid use disorder. If there is any other admitting diagnosis, then we can start methadone, and we are not obligated to follow the federal regulations in terms of the dose titration. So when we do initiate methadone, we do not want to exceed initial dose of 40 milligrams in the first 24 hours. And so again, there's option number 1, we can give 10 milligrams every 4 hours as needed, but not exceeding 40 milligrams in the first 24 hours. Or option 2, we can give 30 milligrams and then reassess in 4 or more hours to see whether or not the patient will need an additional 10 milligrams. In the setting of fentanyl use disorder, almost every patient is going to require that additional 10 milligrams. So for the most part, option number 2 is really the option that we tend to use most frequently. Methadone dose titration. So in the community, it is incredibly slow how quickly the methadone clinics can titrate methadone. They can titrate anywhere between like 5 to 10 milligrams every like 3 to 4 days. So in the inpatient setting, it really gives us this opportunity to do a much faster titration. And if we can get the patient dose higher, then when they leave and they leave with that last dose letter, the clinic is able to start with a higher dose and get to the patient to a therapeutic dose faster. Now, in the setting of fentanyl use disorder, we're starting to see a little bit more aggressive titration protocols in the hospital setting. And for instance, this particular study came out last year and is showing the use of 30 milligrams in day 1 and then increasing by 10 milligrams every day until you get to 60 milligrams. Boston Medical had just published a protocol where they give 40 milligrams day 1, 60 milligrams day 2, and 80 milligrams day 3, which 10 years ago would have seemed incredibly way too fast, but we are seeing that patients with fentanyl use disorder are needing much higher doses. Now, if somebody comes in and says they are on methadone, it is very important that we confirm their dose. We want to call the methadone clinic, we want to get current dosing, and we want to know when the last dose was. If we are unable to confirm this, we do need to start at 40 milligrams a day on day 1. We shouldn't take the patient's word for it or refer back to previous medical records and to see that the previous admission they'd gotten such and such amount. You have to have that confirmation with the methadone clinic. Okay, so back to our case. So it's 2 years later, and our patient who had this complication of endocarditis, he's on methadone, he remains in remission, and now he's admitted for acute pancreatitis after a weekend of binge drinking alcohol. So step one, we want to call the methadone clinic. And so we do that. We call the methadone clinic and the dose is 120 milligrams, and he did receive a dose yesterday. So how do we manage his acute pain? He's on methadone. He has acute pain. Do we order methadone 120 milligrams, his home dose daily, and add hydromorphone? B, do we order methadone 30 milligrams every 6 hours and add hydromorphone? C, do we hold the methadone and just convert everything into an equivalent dose of hydromorphone? Or D, do we continue the home methadone and manage the patient with non-opioid medications because we don't want to destabilize the patient and cause a relapse? Well, the answer is A or B. Two different ways we can do it. We can administer the home dose as one dose, or we can try to take advantage of that analgesic window of 6 to 8 hours by spreading the dosing out. When doing that, it is important to note, though, that the patients are not going to really get really much considerable pain relief from methadone, and we really don't want people to be considering that it is providing any type of pain relief. But either way, you can either way you can do it, as long as the most important thing is that within 24-hour period, the patient is getting their entire home dose. We want to address acute pain via a multimodal approach. So non-pharmacological options, we want to think of non-opioid pain medications. And then when we're thinking of using opioids, we do want to use the short-acting full agonists. We want to be concerned about relapse if pain is untreated. Untreated pain is more likely to cause relapse than introducing full agonists to treat pain. Okay, so let's move on to another case. We have a 56-year-old man, opioid use disorder, on buprenorphine, has diabetes, admitted for a left diabetic foot infection, and is going to require amputation in a couple of days. He's been stable on buprenorphine, 8 milligrams sublingual BID for the past 3 years. So what should we do with his home buprenorphine while managing his perioperative pain? A, do we want to hold the buprenorphine since it is a partial agonist and will impede acute pain control? B, we want to increase the buprenorphine to 8 milligrams sublingual every 8 hours. C, let's just transition to equivalent dose of methadone. D, we want to divide the home buprenorphine to 4 milligrams every 6 hours to take advantage of the analgesic window. Or E, B and D, or B or D. So we want to divide the home buprenorphine to 4 milligrams sublingual every 6 hours as needed. It's not entirely wrong just to continue him on his 8 milligrams twice a day, but it does make it a little bit easier if we are to separate it, because there are times that we do want to reduce the overall buprenorphine dose. And in doing that, if we do reduce the dose, we will open up some of those mu receptors, but it's very important that if we try that strategy, that we are not reducing the buprenorphine dose less than 8 milligrams in a day. If we keep somebody on 8 milligrams at minimum, then they will not run the risk of needing a reinitiation of buprenorphine at the time of discharge. But for the most part, we want to keep the home dose the same within a 24-hour period. So first and foremost, we do not stop the buprenorphine. That was something that was done many, many years ago, and we realized that that was a disaster. Patients required reinitiation, patients were at risk for destabilization and at risk for relapse. We can consider giving the buprenorphine in divided doses. And again, we want to think about non-pharmacological options, non-opioid pain medications. And if we are going to add short-acting agonists, they need to be high-dose, high-affinity, IV short-acting opioids. And this is largely going to be hydromorphone or fentanyl. For the most part, for a lot of institutions can't use fentanyl on the floor, and therefore hydromorphone would be the drug of choice. It is the medication that we use most frequently, because you do have a medication that the buprenorphine has a very high affinity for those mu receptors. And if you're going to get pain control, you need something that also has a high affinity. So in this patient, our opioid pain management plan would be to switch the buprenorphine to 4 milligrams sublingual every 6 hours and to add hydromorphone 2 to 8 milligram IV every 3 to 4 hours as needed for pain. Now, I just to note that is IV, so 2 to 8 milligrams IV. I generally would recommend that if somebody is on 16 milligrams or more of buprenorphine and you need something for pain management, starting with hydromorphone 2 milligrams every 3 to 4 hours is likely the best strategy. But you shouldn't be surprised if it requires you to titrate that dose up to 8 milligrams or more. You do have to keep in mind that the buprenorphine is occupying those mu receptors. So please don't order 0.1 or 0.2 to 0.4 milligram doses of hydromorphone. This is something I see commonly done. That is not going to do anything for our patient. You have to at least have 1 milligram, and really for adequate pain control, a patient's most likely going to need 2 milligrams IV. Okay, let's spend some time talking about fentanyl. Fentanyl is the single deadliest drug threat our nation has ever encountered, which is what was said by our DEA administrator, Ann Milgram. We know that many people die every day from overdoses. So fentanyl, it's a medication that's been around for a long period of time. It was synthesized in the 1950s, and when it was created as a means to create a drug with a greater safety profile than morphine. It's about 100 times more potent than morphine and about 40 times more potent than heroin. It's important to note that the fentanyl in the street is not diverted pharmaceutical grade product. It is product that's being made in clandestine labs throughout the world. And for many reasons, what we are seeing is that these labs are starting to or have been tweaking the molecule of fentanyl in different ways that are changing the molecule dramatically. And they're doing this largely because if you can change a molecule a little bit, then it's not a molecule that falls under the illicit drug directory. So what is happening is there are 4 structural features of this molecule that are being changed. And when you change any aspect of the molecule, you can change the potency and the kinetics dramatically. And for instance, we have carfentanil, which is about 100 times more potent than fentanyl. And some of these new synthetic opioids that are derived from fentanyl, we worry that are not even being picked up by our drug screens. So let's talk about a case. We have a 26-year-old man with a past medical history of multiple substance use disorders, including opioids. He has depression, PTSD, and he's presented to the ED with left wrist cellulitis. So he tells you that he's been injecting about 3 grams of fentanyl daily. Last use was a few hours ago. He's seen by ortho. Ortho wants to get a CT of his wrist, but they think he needs to come in for IV antibiotics. So he needs to go to general medicine, not their team. And he arrives to the floor. And so when you see him, his COWS is 4. His urine toxicology screen is positive for amphetamine, cocaine, and fentanyl, not surprisingly. He had experienced self-inflicted buprenorphine precipitated withdrawal in the past. However, he is requesting to initiate buprenorphine during this admission. Okay, and so what is COWS? COWS is the Clinical Opiate Withdrawal Scale. And this is a scale that is looking at 15 signs or symptoms of opioid withdrawal. And each item is being scored, and you take that cumulative score, and that gives you an idea of the severity of the opioid withdrawal. So how do we want to proceed with the buprenorphine initiation in this patient? So we have 3 ways we can do this. We can do a traditional approach, we can do a low-dose approach, and we can do a high-dose approach. So let's start off with the traditional approach and see how our patient responds. So the traditional buprenorphine initiation, and this predates fentanyl, the way we would do this is we would wait for 6 to 12 hours from the last opioid use. And in general, it would be heroin or oxycodone. So you would wait, if you waited for at least 12 hours, you know that for the most part, the medication is largely metabolized. You also want to couple this with looking at the COWS score, which is giving you an idea of the severity of the patient's opioid withdrawal. So if somebody had a COWS greater than 8 and it's been over 12 hours, in the traditional model, we would give 2 to 4 milligrams sublingual and the patient would look better. Their COWS would decrease, therefore, signifying that their opioid withdrawal has improved. So in our patient, his COWS is 4. And so we're wanting to do this traditional approach. So we're going to wait because we want the withdrawal to worsen. And so our goal is a COWS greater than 8. So we wait and we come back the next morning. So it's been about 14 hours since you've seen the patient, and now his COWS is 15. And so it's been many hours. It's been at least about 24 hours. It's been at least 14 hours since you saw the patient, and your COWS is greater than 8. So you start your buprenorphine initiation by giving the patient 2 milligrams sublingual times 1 dose. And then 20 minutes later, the nurse tells you that the patient is not looking well. So you go in the room, the patient is diaphoretic, tremulous, very restless, vomiting, very anxious, tearful, and the COWS is 27. So what has happened in this situation? Your patient is experiencing severe buprenorphine precipitated opioid withdrawal. And this is it's horrific to even see happen. I can't even imagine what the patient is going through. And so what happened? Because we waited enough time, the COWS score was high enough, we gave the appropriate dose, but yet the patient felt sicker. Well, before we go into that, let's talk about how we treat it. So we have somebody who's in precipitated opioid withdrawal. We need to act quickly. And counterintuitively, we need to give more buprenorphine. So this is a protocol that is out of the California Bridge program. And later in the presentation, I'll give you some more information about this program where you can pull a lot of protocols. And so first thing you want to do is give more buprenorphine. So you want to give initially a 16 milligram sublingual dose and a 2 milligram dose of lorazepam. Then you want to monitor for the symptoms. Have they improved? If not, we want to give more buprenorphine, another 16 milligrams. And then in addition to that, we do have additional medications that we can consider, such as antipsychotics, alpha agonists, and gabapentin. If we've done these things and we've given the patient a total of 32 milligrams in addition to the dose that caused the withdrawal, and we've used additional medications to try to manage our symptoms, if the patient is still sick, then the medications that you want to consider at that point in time are ketamine and fentanyl. And that this is usually going to mean that the patient needs to be in ED or transferred to the ICU. And so this is something that about 5 years ago, we were starting to see patients being thrown into precipitated withdrawal after using fentanyl. And it was mind-boggling because fentanyl has an incredibly short half-life. And so we were wondering what in the world's going on. But what had never been considered is that this repeated high dose being used daily and the effects that was having on the kinetics of the medication. And so what we knew about fentanyl at that time or now is that all of the studies that were done on fentanyl back in the 1950s was based on a single dose or multiple doses within 1 day. And from that information or from those studies, we were able to determine that fentanyl has a half-life of anywhere between 1.5 hours to 6 hours. We knew that fentanyl was highly lipophilic, and we knew that it had a high affinity to the mu receptor. It's this high lipophilicity, though, that was causing the problem. Fentanyl is incredibly lipophilic. For instance, as an example, so there is a partition coefficient called the octanol water partition coefficient, and morphine is given a coefficient of 6. Fentanyl has a coefficient of greater than 700. So what is happening is these large amounts of fentanyl that are being used on a daily basis are being sequestered into the adipose tissue, and they're being stored there. And it's essentially acting as if it's it has a long half-life, a slow release type of product. This is making it incredibly difficult to get people onto buprenorphine. What we're seeing now is that patients are taking weeks to metabolize fentanyl completely. So there was a study looking at 12 patients who had come in for treatment of fentanyl use disorder, and they checked their urines every 2 to 3 days and found that patients on average, the fentanyl was positive for 7+ days, and the norfentanyl was positive for 13+ days. And one patient had tested positive for a couple weeks. And we're seeing this pretty commonly now. So this fentanyl is lingering around for a long period of time. And so this traditional approach that we all used to use, we cannot use it any longer in the setting of fentanyl use disorder. It is considered outdated. So what to do? So we've come up with these new ways to initiate buprenorphine, and one is called the low dose initiation. And in this low dose initiation, the concept is that if you give tiny little amounts of buprenorphine, you know that the buprenorphine is going to come in and it's going to rush to the mu receptor. It's going to bump off whatever is on the mu receptor. But if you're giving it in such tiny doses, the hope is that you're going to get this exchange on the mu receptor that is going to cause little to no withdrawal symptoms. And because it has such a low dissociation and long half-life, you can slowly just continue to give slightly increased doses of buprenorphine until you get somebody whose mu receptors are primarily occupied by buprenorphine. The important thing to note about this strategy is that you have to have an overlapping full mu receptor agonist. And you need to do that because you want to prevent the natural withdrawal from occurring while you're doing this exchange at the mu receptor. This was really first published back in this method and back in 2016. And as you can see, the buprenorphine doses were very tiny. We're talking about starting with 0.2 milligrams a day, keeping in mind that a lot of patients at this point, a lot of patients now are requiring anywhere between 24 to 32 milligrams in a day. So 0.2 is incredibly small. In this particular protocol, this was an outpatient protocol, and they were instructing the patients to continue to use street heroin as they were doing a slow initiation. And there are various ways you can do this. There are formulations that you can get microdoses from transdermal patches, from buccal films. You can have people cut the sublingual films. There are various ways to do this. If you are interested in getting this started in your institution, this is a great article to refer to, low dose initiation of buprenorphine. And this is really a stepwise approach to creating a guideline within your own institution. It really talks about how to partner with your pharmacy and your pharmacists, kind of looking at what formulations you might already have on your formulary to do this, and then gives you ideas of various protocols. Okay, so we're back to our patient. So let's pretend like that never happened. And we're now meeting the patient again for the first time, and COWS is 4. And same scenario, he is wanting to get on to buprenorphine. So this time we're going to do a low dose buprenorphine initiation. And his COWS is 4. Now, this is our goal. When we are doing a low dose initiation, we want to avoid withdrawal symptoms as much as possible. So we want someone's COWS to be less than 8 and ideally less than 5. So the first thing you want to do if you're going to do a low dose initiation is you want to start a full opioid agonist immediately. And oftentimes we'll do that with methadone. And so we get somebody on methadone, usually going to require 40 milligrams a day. And then we start our buprenorphine sublingual or buccal protocol, or however your institution decides to do it. In this situation, in this case, we used a protocol that used the buccal films, called the brand name being Belbuca, and in little tiny doses. We're talking the first film is 225 micrograms. And you're giving methadone in addition to that. And each day you're slowly building on that dose, eventually converting over to the sublingual films and continuing the methadone dose until you've gotten to a point where somebody is receiving a therapeutic dose, and then you can stop the full agonist. And in this situation, we do want to be mindful that the maintenance dose is going to probably be 24 to 32 milligrams. So it used to be acceptable to titrate somebody to 16. For the most part, you want to titrate them to 24 in the hospital and plan to discharge them on 24 milligrams daily. This is where that protocol was derived from, if you're interested. Okay, and so that's the low dose approach. Even more recent is a new approach called a high dose approach. And now the high dose approach is the complete opposite. So it is giving very large doses of buprenorphine over a very short period of time. And what we know is that if you give very high doses of buprenorphine, the agonist effect is going to be much greater than the antagonistic effect. And so the hope is that that when you give these high doses of buprenorphine, when it rushes onto the scene, it's going to be bumping off the full agonist and it's going to be causing withdrawal symptoms. But the hope is that if you can give a large enough dose that although you are bumping off some of the full agonist that's present, you are also interacting with receptors that were otherwise empty. And so hopefully that cumulative partial stimulation is matching the full stimulation that was present prior to you starting the buprenorphine. There have been two key papers published on this method, one in 2021, and this was done in an ED out in California, and they were looking at the safety and tolerability of high-dose initiation, which they defined as greater than 12 milligrams. They looked at this approach being done in almost 600 patients, and they found that less than 1% of patients developed precipitated withdrawal. These findings were duplicated a couple years later in a paper that was studied looking at a similar approach, the high-dose approach, but over 28 emergency departments across the country. Patients were receiving anywhere between 8 to 16 milligrams of sublingual buprenorphine, and they looked at 1,200 patients and found, again, less than 1% of cases developed precipitated withdrawal. So how would that look for this patient? So again, we're walking back. We're just meeting him for the first time. His COWS is 4. So in the high dose initiation, we want the withdrawal to worsen, because what that tells us is there are more and more unoccupied mu receptors present. And so we want to wait for COWS to be at least 8, but the higher, the better. And so we come back 14 hours later, our COWS is 15. So now we are ready to start our high dose initiation. And this is how that would look. So let's say it came back in the morning, we ordered a dose of sublingual buprenorphine at 16 milligrams. At that time, the patient's COWS is 15. We come back an hour later, and the patient is actually looking a little bit better. And so the next step would be to repeat that 16 milligrams again. So most high-dose initiations, most protocols will prompt you to give the patient a total of 32 milligrams sublingual buprenorphine. And then at that point, the patient is fully initiated, and you can then transition to the maintenance dose of 24 milligrams, which generally we give 8 milligrams sublingual 3 times a day. This is, again, coming from the California Bridge program. This is a really nice protocol to duplicate for high-dose initiations. It is, again, what we just did, giving the patient 16 milligrams, looking to see whether or not withdrawal has improved, and then giving a second dose anywhere between 8 to 24 milligrams. And just to note, this is exactly what we're doing when patients have precipitated withdrawal. So in both situations, we're giving higher doses. In both situations, we're giving 16 and then repeating with another 16. So in this situation, this is our patient. And, in the initial situation that I presented, the patient's COWS went from 15 to 10 after getting 16 milligrams. In this situation, let's assume that you give 16 milligrams and it throws the patient into precipitated withdrawal, and they're now requiring 24, or sorry, their CALs went from 15 to 24. What do? You repeat the 16 milligrams. Either way, regardless how the patient is looking, you want to repeat that 16 milligrams. And there are some protocols now that just give the 32 milligrams up front. But sometimes this is a lot to have in the patient's mouth and for a lot to be dissolving at one time. This is the information regarding the California Bridge program. I'd really encourage you to go to this protocol or this website. They have all their protocols listed. They're really great tools to be able to initiate something like this in your institution. Another great resource is the American Society of Addiction Medicine statement on buprenorphine. Gives you a lot of information about how to do these various initiations. And so just quickly, a couple more slides, just comparing the low dose to high dose. The low dose is going to take 3 to 7 days. The high dose is less than 2 hours to complete. So huge difference there. But the low dose is really going to be your go-to if somebody is dealing with chronic or acute pain and they're needing full agonists, if they're having any type of acute medical issues that are going on. The high dose is great in that you're giving it in less than 2 hours. The patient's fully initiated, and so you avoid any incomplete initiations due to a self-directed discharge. And talking points. How do I approach the patient? So this is important because patients are scared of precipitated withdrawal, and it's not uncommon for patients to say, I'm not going to consider buprenorphine. But the two things you want to get from the patient is how scared are they from precipitated withdrawal, and how much time are they willing to stay in the hospital? And what I tell them is that we can do this low dose approach. You don't need to worry about precipitated withdrawal. It's not going to cause precipitated withdrawal. The doses are very tiny, and we are going to continue giving you pain medications while we are doing this. That's a huge selling point. We also want to prep them that this can take a while, and this means you're going to be in the hospital for many more days. In talking about the high dose approach, I let them know, yeah, the studies show this. I don't necessarily say that, but you could experience precipitated withdrawal. I know the studies show less than 1%, but that's not what we've experienced. I've seen it happen a lot more frequently than that. So you want to prep the patient, and you want them to know the longer you can wait before we do this, the sicker that you feel, it's going to be, the less chance you're going to experience precipitated withdrawal. But it's important that you tell your patients that if you get sicker, we're going to treat you. We're going to give you medication. But the first thing that we're going to do is give you more buprenorphine. And it's important to tell the patient that before you even start this process, because they're going to think you're bonkers when they're feeling like trash, and then you're telling them, take more. And so I prep the patients ahead of time saying, like, if you get sicker, you're going to need to take more, and that's the way you're going to feel better. And then also sell it as, it's just going to be 2 hours, and then we're done, and then you're initiated. And so lastly, just a quick case on a patient who presented with active fentanyl use disorder, who had relapsed to fentanyl about a month prior. There are some pretty graphic slides coming up, just FYI. But this is a case of a patient who had very severe wounds from xylazine. And I imagine a lot of you are starting to see this now, but just really horrific wounds that we're starting to see. And xylazine, as we know, is starting to impact all across the country. It was first seen mostly in the Northeast, but something to look for and something to consider. In this particular patient, she was seen by infectious diseases. She got a short course of antibiotics, but really the most important thing is that patient get intensive wound treatment. And then 2 weeks later, her wounds were already looking better. But in summary, please, methadone can definitely be given in the inpatient setting. And so use your inpatient admissions as an opportunity to start methadone and to start buprenorphine. It's not as easy to do in the community. Do not stop buprenorphine if someone is coming into the hospital for any reason, if they're already on it. And get familiar with these initiation strategies. We as hospitalists are really well positioned to really impact the opioid epidemic if we utilize our skills in the inpatient setting to get people on medication for opioid use disorder. Thank you.
Well, thank you very much for that outstanding talk. I think we have time for maybe one or two questions. A couple of people in the audience were wondering if buprenorphine is not available on formulary, how would you handle that in the inpatient setting, assuming a patient can't bring in their own supply?
The first thing I would do is to go and down to the pharmacy and have a, and get a relationship with your pharmacist. I have found that we've been able to accomplish a lot by partnering with our pharmacist. Also, going to your P&T committee and talking about this. This is really a medication that should be standard. It should be on all formularies. And if it's not, seek out your P&T committee, seek out your pharmacists, and bring them the evidence and really campaign to get this on your formularies. It's so vitally important.
Okay, well, thank you so much, Dr. Vercollone, for that wonderful talk. Unfortunately, we're out of time, so we'll transition on.